Welcome, colleagues, to this year's Faculty of Public Health Bazalgette Lecture. I'm Professor Kevin Fenton, the President of the Faculty of Public Health, and it gives me great pleasure to welcome you all here this morning. Now, in 2019, the Faculty of Public Health launched the Bazalgette Professorship Champion of Evidence Award in collaboration with the Alliance for Useful Evidence. The award recognizes a Fellow of the Faculty of Public Health for major contributions to public health policy and or practice through research translation for the benefit of the UK population. Now, before I introduce this year's winner of the Bazalgette Professorship, I have a few bits of housekeeping. First, this meeting is going to be recorded, and the recording and the slides will be available as a resource to faculty members in the next edition of our faculty's e-bulletin. There will be a question and answer session and discussion session at the end of the meeting, so please feel free to post your questions either in the chat or in the QA function, and we'll be coming back to them during the course towards the end of the lecture. Now, it's time for me to introduce our distinguished lecturer for this morning. Professor Laura Shallcross, MBE, is Professor of Public Health and Director of the UCL Institute for Health Informatics. Laura received her MBE for Public Health in 2021 for her work on the VIVALDI study. Professor Shallcross was awarded the FPH Bazalgette Professorship Champion of Evidence Award in 2023 for her role in shaping the UK policy to reduce COVID-19 transmission in care homes through her work leading the VIVALDI study. Professor Shallcross's research provided critical insights into the care home practices that made them so vulnerable to COVID-19 transmission and informed key policy decisions, including the prioritization of staff testing, limiting movement between staff, between care homes, and the need for and the timing of booster vaccinations. Now, as well as leading the National VIVALDI study, Professor Shallcross was a member of the Scientific Advisory Group for Emergencies, SAGE, Social Care Working Group. Currently, Professor Shallcross leads a collaborative interdisciplinary program of research which is focused on reducing the impact of infections, outbreaks, and antimicrobial resistance across health and care settings. Her research is delivered in partnerships with relatives, residents, care home staff, care providers, patients, and policymakers, with a strong focus on translating research findings into policy and practice. Laura, congratulations on receiving this award, and we look forward to your lecture this morning. Over to you.
Thank you very much. I think that is definitely the nicest introduction I've ever had, and it's a real privilege to be with you today. And I'm looking forward to telling you about the work that we did in VIVALDI and how we work with policymakers, and also the work that we're continuing to do now. So once slides are up, off we go. So next slide, please. So if I can just take you back to the context in which we set the study up in the first place. And so many of you will be very familiar with these kinds of headlines that were prevalent in the first wave of the pandemic. So this sense that a lot of bad things were happening in care homes, there were lots of deaths, but also this feeling that we just didn't have a good handle on what was going on. We didn't have the data that we needed to inform public health action. And this is really illustrated by this graph from the Office for National Statistics that shows the number of deaths in care homes in the first wave of the pandemic. But if I can draw your attention to the red line, that shows when the whole care home testing programme was first piloted in care homes. And so you can really see that by the time that programme had come in, we'd missed the first wave. And this really was one of the key challenges, particularly for care homes, that we didn't have the data that we needed to try and inform evidence-based policy and decision-making. Next slide, please. And so that's why we set up the VIVALDI study. It was all about trying to generate the evidence to guide policy relevant questions. And so it's a government-funded programme of research. We started in May 2020, ended up running for nearly 3 years. But the only reason the programme worked is because it was delivered in very close partnership with care providers. And our goal and emphasis throughout was really not research as usual. It was a new way of doing research, all about rapid timescales, high quality, and as I've said, trying to inform policy. Next slide, please. And so the first thing that we did in VIVALDI, as Professor Fenton has alluded to, is to try and answer what should have been two fairly simple questions. So we wanted to get a sense of how many people in care homes had been infected in wave one, but we also wanted to get some insights into why some homes were getting outbreaks and large outbreaks, and others seemed to be relatively unscathed. But because of the challenges with setting up the testing infrastructure that I've already mentioned, we couldn't get that information from routine data. And so we realised the best approach was to do a telephone survey of care home managers. And so we had a big collaboration. We worked with the Office for National Statistics, Department of Health, Public Health England as it was then, and were able to survey over 5,000 care home managers in a very short period of time, in around 6 weeks. So we brought that data into a central location in the NHS, did some linkage, did our analysis, and then pushed our findings through to policymakers as quickly as we could. Next slide, please. So to cut a long story short, what we found was that around 11% of residents and 4% of staff had tested PCR positive in wave one. Of course, we know that's a big underestimate because of the challenges around testing. But probably more usefully, we were able to get some insights into the kinds of care home factors that seem to be important in the spread of infection and outbreaks. And so the lines that are primarily red here are the ones that came out as being important. So to give you some examples, we found that care homes that didn't pay sick pay to staff, they were more likely to have infections in residents and their staff. We found that care homes where staff were regularly working across sites, they were more likely to have infections in their staff. And so whilst I certainly am not about to pretend that this was a perfect study, it was cross-sectional, because at the time there was so little information on the strategies that might work to limit the spread of infection, this work was extremely valuable for policymakers. Next slide, please. And so we had a lot of impact. Our findings supported the decision to focus the limited testing capacity on staff rather than residents, because we showed staff were more likely to infect residents than vice versa. Our findings around sick pay supported the government's decision to establish the Adult Social Care Infection Control Fund, and that, as many of you will know, provided flexible funding to providers so care home staff could afford to self-isolate when unwell, really important to limit the spread of infection. And our findings around staff movement informed the decision to limit movement of staff to reduce transmission of infection. Next slide, please. But of course, we realised that a cross-sectional survey was only going to get us so far. It's a snapshot at one point in time. And really what we needed was to be able to follow people up in care homes over time to see what happened to them. And so this is why we set up the VIVALDI cohort study, which originally set out as a seroprevalence survey. So the idea being we worked with a single care provider in around 100 care homes, and we would do serial blood sampling in staff and residents in those homes. And so that would let us measure antibody levels. It would let us look at aspects of cellular immunity too, and that we could then track outcomes in people who were and weren't infected. But then our funder, the Department of Health, asked us to do a bigger study. They said, you need more care homes, we need more diversity. Very fair point. But also, because of changes in the testing and data infrastructure that were taking place in the pandemic, we realised there was a major opportunity to really broaden the scope of what we're doing and to have a lot more impact. And so we realised we could link to the COVID test results, not just from that subset who were being blood sampled and consenting to that, but actually for everybody in the care home, because of changes to information governance, data protection that were brought in during the pandemic. And so what this allowed us to do was, through data linkage, was to develop a really detailed care home linked data platform for care home residents and staff in all our participating care homes. And this is what we've subsequently used to deliver all our research in VIVALDI. Next slide, please. So very briefly on how this works and why it's important, because it really is fundamental to everything that we've done and what we want to do in future. So one of the key challenges with doing research in care homes is that we don't have a registry of care home staff or residents. And so what that means is if you want to do large-scale studies in this population, you don't have your denominator. But because everybody in care homes was being tested regularly during COVID, and very regularly, so this was at least weekly for staff at the beginning and monthly for residents, those tests were bringing in their NHS numbers, so their unique identifiers linked to an ID for their care home, the CQC ID. And so that effectively established an accurate, regularly updated registry of those staff and residents. That information was brought into NHS England, so secure environment. And because the other relevant routine data sets are held in that environment, we could then link across to them via the NHS number. And so this allowed us to have this linked data platform that could be used for research. Of course, this was only permitted during the pandemic. Next slide, please. And so very briefly, this was permitted because of the so-called COPI notice, so changes that were brought in by government to permit data sharing to support the pandemic response. And this notice was withdrawn in July 22, and so we had to use different strategies to continue accessing data from residents, which bring a whole range of other challenges that I will talk a bit more about in a moment. Next slide, please. So we were able to use this data platform to deliver an array of research studies. So to give you some examples, we were able to look at vaccine effectiveness in care home residents and staff. We were able to look at humoral and cellular immunity, and that was working with Paul Moss's group in Birmingham. We were able to look at important policy questions like the risk of reinfection. And we were also able to shed insights on the emergence and severity of variants in this population. And that was great. You know, as academics, of course, we want to publish papers, but really what motivated our team was about getting these findings to policymakers to inform decision-making as quickly as possible. And so we did that in a number of ways, presenting regularly to NERVTAG, the New and Emerging Respiratory Virus Threats Advisory Group. As Professor Fenton said, I was a member of the SAGE Social Care Working Group, so that provided a really good mechanism to get our early data under the noses of decision makers. And we were able to inform quite a lot of policy documents, some of which I've listed here. And as somebody who's come through the UK public health system, I was particularly pleased that we informed the chapter of the Green Book, because that was certainly not something that I ever expected to do in my career. Next slide, please. So I thought I would just give you a few examples of how we use this linked data platform to answer policy relevant questions. So if you can cast your minds back to pre-vaccines, one of the key things that people wanted to know was whether people could get infected with COVID more than once. Could those who'd been infected and survived be reassured that that was it? It was not like flu. They weren't going to keep getting this every year or couple of years. And so, as I've mentioned, because of the challenges with setting up PCR testing in care homes, we couldn't use the PCR data to answer this question. And that's really illustrated by this graph here, which shows the number of PCR tests in our 100 care homes, so that first seroprevalence cohort that we used. And what you can also see is for that first peak, so not only is it quite small, because many people weren't tested, but it's also yellow-orange in this picture. And that denotes the fact that we didn't know if those samples were coming from residents or staff, so another barrier to using that data. But you can also see, as we then move into wave 2, into autumn-winter 2020, that first of all, the amount of testing increases, but secondly, we see the blue and green. And so the data accuracy is improving. We're able to differentiate samples from residents and from staff. And so because we were able to do blood sampling in this cohort, and that started from around August 2020, we could use our blood testing to measure antibody levels. So that told us who had been infected in wave 1, and so obviously only in survivors. But then we could track those antibody negative, antibody positive people into the next wave and see who tested PCR positive. Next slide, please. And so this was work that was led by Maria Krutikoff, my PhD student. And we found that around 30% of staff and residents had been infected with COVID. But more importantly, we found in wave 1, but more importantly, we found that among those who were antibody positive, they were around 7-fold less likely, residents, to become infected, to have a new infection than those who are antibody negative. And so pre-vaccines, this was tremendously reassuring information, both for people in care homes, but also for policymakers, that at least if people had had it, it seemed that there was fairly good protection from a subsequent infection. Next slide, please. Another aspect that we were able to look at was the emergence of variants. And so, as many of you will recall, in autumn 2020, because we had such good sequencing data in the UK, we were able to track the emergence of a new variant, the so-called Kent or Alpha variant, and to track it as it emerged from the southeast of England and subsequently moved across the country. But unfortunately, we never were able to get good quality sequencing data from care homes for various reasons. And so that was not an option in that population. But because we had our linked data platform, and because of peculiarities about how the gene targets for PCR worked, we were able to track the switch from the Wuhan strain, so the original variant in blue here, through to green, the Alpha variant, as it emerged in care homes in the southeast and then subsequently across the country. And so this was really important because at the time, there were very strict control measures in place in care homes, so lots of testing, but also limiting, relatives were not allowed to visit, lots and lots of measures in place. And what this study showed was that that was failing to keep transmission of infection out. It was absolutely still coming in from the community. Next slide, please. Probably the most important work that we were able to do was to demonstrate the effectiveness of vaccination in care home residents. And the reason this mattered is because residents were excluded from the original vaccine trials, and there was a substantial concern that vaccines might not work so well in this population, bearing in mind that vaccines like flu are often less effective in this older age group. And so using our linked data platform, and this was work done by Maddie Shotry, who is now an infectious disease registrar, we were able to estimate the effectiveness of initially first dose vaccine, but subsequently all the different doses and booster vaccinations. And we were able to show very quickly that there was a significant, so 62% reduction in the risk of infection after 35 days in care home residents. And so again, very reassuring information for people in care homes and for policymakers that vaccines were effective in this population. And as I've said, we continue to do this sort of work with each of the vaccine rollouts. Next slide, please. So that's a bit of a whistle-stop tour of the work that we did during COVID. But now what I wanted to do was to talk a bit about how we're trying to build on this moving forward. And so alongside the work that we were doing to support the pandemic response, we were really motivated to think, well, if we can do this kind of work in a pandemic, imagine what we could do beyond the pandemic if we could adopt similar approaches to tackle initially other kinds of infections, antimicrobial resistance, but potentially to address the array of health conditions that are extremely prevalent in this population. And so this led to the idea of a long-term programme of research and surveillance at that interface between health and care. But what we also realised was that it would have to be co-produced with the care sector, otherwise it wouldn't work. And we really wanted to have this focus on using data for action. Next slide, please. And so we started to try and think about what such a programme could look like. And I'll try and talk you through this diagram now. And so we had the idea that if we could set up a network of care homes initially for older adults and of the magnitude of, say, 500 to 1,500, so roughly 10%, and that these homes would be research motivated and that they would be willing to share very limited data on their residents, so initially just NHS numbers. And that would give us that important registry of the care home residents, And we could then do similar data linkages as we've done in VIVALDI to measure things that are relevant and useful for people in care homes. So we could measure rates of infection, we could measure rates of hospitalization, we could look at things like vaccine coverage, and then feed that back and allow care homes to benchmark their performance against others, helping them to target and prioritize their activities. And so that's the blue section of the diagram here. But of course, what that data infrastructure also does is it unlocks the potential to deliver more complex studies. So to give you an example, your data could tell you which care homes have high or low rates of antibiotic prescribing. You can then go and do targeted interviews, ethnography in those care homes to understand what's driving those different behaviours. And that helps you then share best practice because you learn what it is that's critical to reduce antimicrobial overuse. But then perhaps most ambitiously, you could start using this infrastructure for clinical trials, and particularly for cluster randomized trials. And one of the key barriers to this kind of research in care homes is that the care home staff are asked to collect additional data, and they don't have the capacity to do that additional work. They're already overstretched. But of course, if you have this data infrastructure, well, much of the information you need is already in the system, and so it becomes much easier. And so you could envisage trials looking at vaccination, or even trials looking at the kinds of infection control measures that were used in the pandemic, where we really needed data to understand how effective they were in this population. Next slide, please. But of course, talk is very cheap. It's really easy to have big ideas. And the challenge is then trying to find a way to make these things happen. And so over the past few years, we've been doing a lot of work with policymakers to try and make the case for why it would be important and the value it could bring. And this is a picture from one of our care home visits that we did in 2022 with Lucy Chappell, Michelle Dyson and Jenny Harries to visit one of the care homes that took part in VIVALDI and find out more about the work that we have been doing. And we've now got a rolling programme of these care home visits where we invite lots of people from public health, local authorities, CQC, and also from across government. Next slide, please. But most importantly, we realised that the project would only work if it was driven by the care sector. This couldn't be a bunch of academics sitting at UCL and elsewhere and saying, you know, this sounds like a good idea. And so we set up a new partnership between us at UCL, Care England, who are one of the largest organisations representing the for-profit sector, and the Outstanding Society, which is an organisation that promotes quality in social care. And we've really worked together to engage with care home residents, relatives, providers and staff, and to co-produce a plan for what this project could look like as a pilot. And that has led to the setup of the VIVALDI Social Care Project. Next slide, please. And so I switched to green here to really illustrate that we're moving from sort of academic-led project to shared ownership, and green is, of course, the colour of social care. And so this project's mission is all about improving the quality of life for people living, visiting in, working and in care homes, while trying to reduce the risk of infection and hospital admissions. But critically, we're trying to do this using routine data because we know that this is a key barrier to participation, and we need to find ways to make it easy for care homes to participate in research, but also we need to give information back that is directly useful for residents and staff and their families. So the project is a collaboration between residents, relatives, staff, providers, academics and policymakers. It's funded by the UK Health Security Agency, but me and my research team are funded by the NHR. Next slide, please. So very briefly about how the study works. And so I've mentioned at the beginning about the importance of care home testing as being the thing that unlocked the potential for us to deliver VIVALDI. Well, of course, testing has stopped, and that's no longer a mechanism for us to bring that information into a central location like NHS England. And so instead, we've been working with the software vendors that supply digital care records to care homes that are taking part in our study. And so we're bringing that information in, just NHS numbers, on a regular basis, so daily we're working towards, into NHS England, and we can then do all the kinds of data linkages that we did in VIVALDI, and hopefully some additional ones, so looking at laboratory test results and antibiotic prescribing too. So that information is then through the linkage, it sets up our care home data platform, and that is then the resource that is available for research and surveillance. Next slide, please. So the information that comes in is identifiable, NHS numbers, but then within the NHS England environment, those NHS numbers are switched for pseudonymized codes. Those codes can be used to link, and then the data is de-identified before it's extracted from that environment and made available to researchers. Next slide, please. So a bit on consent and data oversight, clearly really important for this kind of project. So we heard very clearly from the care sector when we started this that they were concerned about how the data might be used, if it might be misused or misinterpreted. And it was really important that ownership and control for how the data could be used rested with the care sector. And so this is why we've set up this particular controllership arrangement. We also have a lot of oversight, both through our Data Access Committee and our Stakeholder Oversight and Governance Group, and residents and relatives are very heavily represented on those groups. And on to the issue of consent, really fundamental here. So what we wanted to do more than anything else was to be inclusive and to maximise the value of this project for residents. But we know very clearly from our own work around blood sampling and also from talking a lot to other academic colleagues, there are such huge challenges around getting informed consent in this population because of high levels of cognitive impairment. And of course, you can use nominated consultees, personal consultees, which we did in VIVALDI for blood sampling, but there is a very significant workload associated with that, and that usually falls on care home staff. And so we knew that if we had an informed consent model, we would miss a very high proportion of the kinds of residents that we really want to be able to support and improve their quality of life and outcomes. So I'm very happy to say that we were able to get approval from the Health Research Authority Confidentiality Advisory Group to pilot an opt-out consent model for this project. But that is then underpinned by a large programme of engagement to make sure that this approach remains acceptable. And we're also starting slowly, taking the minimum amount of data with the goal to build trust and hopefully longer term be able to use more of the data that exists within digital care plans. So I'm going to move on to the next slide, and hopefully this is a video that will give you insight into how we're communicating this to care home residents. I can't hear that. I don't know if anyone else can.
Could you hear it? No.
No, couldn't hear it.
Okay, just give me 1 minute. If not, we can send it out. If I can just have 1 moment, please. Okay.
The VIVALDI study was set up in 2020 to monitor the spread of COVID-19 in care homes. We've come a long way in fighting the virus, armed with a range of vaccines and a greater understanding of how it affects us. We now want to apply what we've learned to tackle other kinds of infections, like flu and gastroenteritis, which can make residents really unwell and cause outbreaks that could stop relatives from visiting. To do this effectively, we need data. What do we mean by data? Data is just another word for facts and figures, information no different to the records kept by the NHS about you, your health, and any treatments or vaccinations you have had. This information lets us build a picture of the nation's care home residents in our collective fight against infections like flu and COVID. It helps us understand how many residents have been infected, their body's response to infection, and the effectiveness of vaccines. We understand that this data is more than just numbers. It's precious and personal, and needs handling with the utmost care. This is why it will only be seen by staff who have been specially trained and approved to protect confidentiality. The data will be anonymized before it is shared with researchers, and it will be kept safe and secure here in the UK, protected by independently assessed security systems equivalent to those used by the NHS. We want all care home residents to benefit, so we would like to collect information on everyone to avoid gaps in the data. We also know that not everyone wants to share their data, so you can opt out if you don't want to take part. It's as simple as speaking to your care home manager or Vivaldi's social care lead to let them know if you do not want your data included. With this data, we can continue to understand how infections such as flu, COVID-19, norovirus, and UTIs affect those living and working in care homes, and the ultimate goal of reducing infections, improving lives, and keeping our care homes open to family visits. The Vivaldi.
Great, thank you. And thank you for sorting out the sound. So that's a quick summary of how we're communicating the project. I'm really pleased to say that we have care homes signed up to take part across all of the integrated care boards. Somebody told me that there were none in the Black Country. Apparently that's not true, so I need to take that off the slide. But we had really good uptake for the project, and this is all thanks to our partnership with the Outstanding Society, because they are able to make those connections with care providers much more effectively than we can working as academics alone. Next slide, please. And so I mentioned our goal was to enroll between 500 and 1,500. So we have 500 homes signed, over 500 signed up already. We have a big training program with these homes. So we go out, we make sure people understand about data, about the opt-out process, and also trying to start to build in a small way a culture of research in these care homes, and obviously giving them the opportunity to answer any questions and meet us. Next slide, please. All our work is overseen by our Adult Social Care Engagement Collective. And so this is a group of around 30 to 40 people. So primarily relatives, care home staff, care providers, charities, organisations like Use My Data. They're an absolutely fantastic, really committed group, and they really do hold us to account. So it's brilliant working with them. Next slide, please. So very briefly on the study outputs. So I've mentioned the importance, the lessons we learned in Vivaldi about doing useful things and giving information back. And so our two key outputs are going to be a dashboard that initially tries to provide useful information about the care home population, raising awareness of that, simple things, but the kind of data that isn't really out there at the moment. And then we're working towards measures of infection and antimicrobial resistance. That's going to be quite hard to do that in the right way. So we're likely to start with things like antibiotic prescribing rates, which are less open to misinterpretation. And those dashboards are aimed at policymakers, care providers, residents, and their families. And then our second output is our research database and working towards a platform. And the idea is this is fully anonymized. Researchers can apply to use it. Ideally, we will be able to have a data platform that can then support more complex studies like trials. That's unsurprisingly going to take a little time. Next slide, please. So then, coming to the end, I feel like what we've learned through this project is some of the things that need to happen to enable care, to enable research and in care homes and more broadly in social care to happen. And I think about this quite simply. I think that there are three elements. You need a care home network, particularly if you want to do studies at scale. You need the underpinning linked data because that makes it easier, it reduces workload. But the real missing piece here is that cohort of staff in care homes who understand what research is, are able to explain it to relatives, to residents, and can support research delivery. And so we're starting to make tentative steps in that direction, working with organisations like NIHR to think about how you could start to build that capacity within care homes. Next slide, please. And then very briefly, just to say that everything I've talked about so far is based on routine data. And that's fine, but it's very skewed towards NHS outcomes, hospital admissions, deaths, bloodstream infections, for example. And what I've really learned is that that's really not the most important thing in care homes, because care homes have people in care homes have other priorities. And so if you want to think about how to influence what providers might do, well, a good lever is to think about how much income is lost when there's an outbreak, because outbreaks close care homes. So they lose income because they can't take new admissions. So are there ways that we can start having a more holistic approach to considering the impact of infections and antimicrobial resistance that resonates more with the right stakeholders? And of course, residents amongst this, here, our focus should really be on quality of life. Those kind of measures are not currently in routine data. And so this is work that, again, with LSE, with my PhD student, Arnoop, on this slide, we're starting to try and think about how we can get that broader set of metrics to capture the impact in the most appropriate way. Next slide, please. And so then finally, our long-term goals for this project, and you probably realise we're getting quite ambitious, so it's probably over a sort of 10-year period, are to try and really enable the delivery of research in social care. And to do that, we need this focus on training and capacity building for the workforce. We want to have a diverse programme of research, so ranging from clinical trials, public health research, but also basic science. Big opportunities if we can take residual samples and use those to look at, for example, the biology of ageing. Big opportunities around surveillance. It would be great to be able to have a cohort of social care workers to look at health outcomes in this population, but also perhaps most importantly, the data that we will have through this programme will really empower the care sector and help to improve people's understanding of where the problems lie, hopefully moving to the kinds of approaches that we have in the NHS, where we very regularly hear headlines about waiting lists or about variation in care quality. And these are the kinds of approaches it would be great to see in social care. Next slide, please. And so to finish, just to say, I'm obviously presenting on behalf of a huge team here. I've just listed the categories of people. It's been an absolute privilege working on this project, and also for me personally, getting to know more about the care sector has been really fabulous. So thank you, and I hope that was interesting for you.
Laura, thank you. That was fabulous, and it was fascinating. And I know I have a lot of questions here that I've already jotted down for you. And I'm sure that those who are listening to the lecture will also have as well. So we're going to spend a little bit of time getting to know you, because one of the nice things about the Bazalgette Lectures is that it's such a high reward from the faculty. We're always keen to learn a little bit more about our colleagues who've won the prize, your history and your work in public health, and what's bringing you to this work at this phase of your career. So I'd like to just start by, if you could just briefly summarize your career to date, and what was your road into public health?
Yeah, thank you. So I think I was probably always destined for public health. As a child, I was quite obsessed with cholera and the plague, to the point where, you know, things like going to the Museum of London, used to really like doing that. And we lived in a long way away from London, so that was a trip. So I was always interested in infectious diseases, and went to medical school and felt a bit like I might be in the wrong place, was very drawn to sort of policy. And so I did an intercalated degree, and so had the option to switch preclinical and clinical medicine. So I took a year off in that gap, and I went and worked at the World Health Organization in Geneva and did an internship and worked on anti-malarial drug resistance, which I really enjoyed, and obviously got insights into being epidemiology, and then went back to medical school and was very fortunate because my dean let me have time off during gynecology primarily to sort of hop backwards and forwards to WHO. So I continued my work on drug resistance, and then did my elective on the Thai-Burmese border, and really felt that maybe a career in tropical medicine was the right way, but always around infectious diseases. Anyway, then came back, did my junior doctor training, and had that decision to make. Was it infectious diseases? Was it public health? Went for public health and followed a fairly standard academic career pathway after that, with fellowships at UCL. My PhD was on Panton Valentine leucocidin, associated Staphylococcus, which is the bane of many people's lives.
Okay.
In health protection. So work on that, and then sort of gently drifted towards antimicrobial resistance. And I found myself doing more and more work on data, electronic health records, primary care, secondary care, bit in care homes. And then COVID came along, and I was asked to set up, I got a grant, a small grant to do some work in care homes because I was really worried that we didn't have the data, and then got a tap on the shoulder and said, can you please set up a big study on care homes? And that was what led to VIVALDI. So yeah, I think a fairly traditional academic career path, probably.
Yeah, fantastic. And that just gives us wonderful context in understanding your lecture today and seeing that passion for public health as early as it happened, but also your journey and exposure to public health, both global health, and then of course your academic track, I think just helps us to put this together. What is it that's so special about working in social care? Because we often see, I mean, for those of us working in community health and public health, we often feel like the neglected sort of partners to the NHS, but I suspect social care feels that way too. So what is it that both attracted you there, but also keeps you working in social care? And would you recommend it to the next generation of colleagues coming up in public health practice?
Yeah, so I would say what attracted me to it in the beginning was the sense that it's uncharted territory. The opportunities here are huge, and there's so much work that is required, and it's not a crowded space. So you do have that opportunity to do lots of different kinds of work. What keeps me there, I'd say, are two things. So one is that I feel very strongly after the pandemic that if we cannot emerge having learned the lessons, if we're not able to say if another one hit in a year, we would be okay to manage this, then personally, I feel like I would hang my head in shame, because it's just, that cannot be. And so that's a massive motivator for me, particularly around VIVALDI social care. But also, more selfishly, it's much easier to get things done, because having worked in the NHS, I mean, the idea of doing anything that will really lead to systematic change in the NHS, it's so difficult because you're working with lots of different trusts. As an organisation, it's huge. So your opportunity to influence and have impact, of course it can be done, but it's much, much harder. In care homes, if you work with large care sector organisations particularly, if you can build relationships with the senior management teams, you can work in partnership. And so I think the partnership working is great. And that's definitely the part of VIVALDI that I enjoy the most.
Wonderful. And, and it sounds counterintuitive, because we'd think that you'd have as diverse and as fragmented a sector in social care as we do in hospital trusts and GP practices and so forth. But you're saying that actually by understanding that ecosystem and understanding where to intervene, you can actually be achieving scale pretty quickly as well.
Yeah, exactly.
Interesting. So what proportion coverage of care homes currently do you have engaged in the VIVALDI program? I know you are at 500 plus care homes, and your ambition is 15,000, but that is of what proportion of the total numbers, just to give listeners a sense of scale in terms of what coverage you have now?
Yeah, so we've always pitched ourselves as sort of sentinel surveillance. So the idea being that we would be able to, over time, be sufficiently representative, which is a really challenging goal, but it would be great to be able to generate out evidence that is relevant across the sector. So our goal is to get to around 1,500, not 15,000, and then we'd be about 10%, roughly 10%. I think that the important thing is recognizing the heterogeneity across the sector and the real challenges around trying to be representative. So how representative we could ever be, I don't know, but we could end up being quite a lot bigger than that, because it's not a lot of work to participate. So I think it's still uncertain where the future of this project lies, but I would hope at a minimum we're able to do that evidence that's generalizable across the sector. That would be really good.
Yeah. So in my reflections on the COVID pandemic, I too speak about the lessons from the pandemic, but I also encourage systems to reflect on the legacies of the pandemic. What are the things that need to fundamentally change, both in terms of organizations, structures, governance, data, evidence, and a range of characteristics? The things that need to fundamentally change to demonstrate that we have both learned from the pandemic and we're doing things differently. What legacies would you like to see coming out of this? I think you alluded to some of these, but I wanted to explore that with you, because as you say, we want to be in a position where, should we be faced with another challenge such as this, we're not going back to ground zero. So let's talk about legacies a bit and your role in creating some of these legacies for a better future.
Yeah, I mean, what I really hope is that we would have this network underpinned by linked data that can lead into action in terms of surveillance. I mean, ideally, it would be enhanced by the ability to do sampling in that network as well, so that very quickly, if there were to be a pandemic or another threat, you have that infrastructure to be able to move very quickly. I think we're well on the way to developing that, but it's also making sure that it's embedded within national infrastructure. And so we're working with NHS England, and ideally this would become part of the federated data platform structures. That's our goal. And then the other piece is around the research capacity in social care. And it's a big frustration that we have this. There's a lot of talk and support about we want to see research in social care, but we've got to recognise that it's not in the NHS. We have clinical research networks funded by NIHR, the Research Delivery Network. That just doesn't exist in social care. So the people on the ground, you're asking people as part of their day jobs to do research on top. Well, we know that doesn't work in the NHS, so why would it work in social care? So I think it's starting to think about, if you're serious about doing research in this sector, what needs to change in terms of the funding, in terms of the training, where the emphasis lies, and that's got to be about partnering with care provider organisations to find out, what do they need to be able to become research active organisations themselves. So yeah, I could talk on this subject for a very long time, I'm afraid. But
we have time, and that's the beauty of the Bazalgette Lecture, in that we do have time to do this exploration with you. And I presume that some of the research architecture that we have in the NHS would need to be rebuilt or strengthened in the care home setting. For example, do you have research strategy committees? Do you have ethics committees? Do you have, data governance committees that can help to create that environment for research to take place? Is that the case? Or did you rely a lot on clearances from NHS, clearances from other sectors to do this work? How does it work in social care?
Yeah, so we, because we're only bringing in NHS numbers and we're not really exploring the opportunities within the digital care records yet, we certainly want to in future, but because of this importance of building trust and going slowly, we were able to use all the NHS mechanisms, so standard research ethics committees and so forth, standard HRA approaches, standard governance. I mean, not straightforward, because there are obviously all the additional issues in the care sector. And we've been very fortunate in that the Confidentiality Advisory Group have worked very closely with us to think about all the issues around data in this population. But to give you an example, I mean, something that I was very surprised by is when applying the national data opt-out, which obviously is part of the requirements, well, this hasn't been done in social care. So it's talked about, but actually the experience of doing it on the ground just doesn't exist. So for quite a lot of these things, it does feel like we're having to be the test case. Yeah.
And I think that reinforces your earlier point about this being really open for young researchers, young public health practitioners coming in as a space for both research and practice, I would argue, and certainly policy as well, to get more public health thinking into that as well, because the sector has been so focused on individual care. So stepping back and thinking about these issues of research, population health, and population health management will be sort of new things that public health people can bring to this too.
I totally agree. And I think public health people are really well suited to this kind of work, because you have to be able to do the listening, the co-product. It's a different model, and this is what we get trained to do. So it's a great space for public health people, I think.
So I have just a couple of other questions arising from your presentation. And the first is around, my sense is that the current and future iterations of the VIVALDI study will be focusing on residents. But we also know that we've learned so much about care home staff, both in terms of their health and well-being, their ability to understand and trust and take up interventions, how care home staff move, the changing demography of care home staff as well, and the implications that has on a number of factors, but also their own workforce experiences as well, in terms of pay, terms and conditions, the turnover of staff. There's so much that we learned during the COVID-19 pandemic. Is Vivaldi only going to be focusing on patients, or do you see other components of this work that helps the department and local teams to get a better sense of workforce, in the same way that in the NHS we also focus on the workforce as well, and we have plans and are able to look at the experiences of our workforce? I wanted to maybe explore that side as well, because it is such an important part of the pandemic response.
I'm really glad you brought that up, and I couldn't agree more about how important it is. So the reason that we are not, so you're right, as in our current iteration, we're focused on residents. The reason for that is because our data mechanism is all about opt-out, and you couldn't use that in healthcare workers. But we are developing a collaboration with the Siren study, so the healthcare worker cohort that was led by Susan Hopkins and Victoria Hall at the UKHSA. And our goal is to adopt the model they have used of the consented cohort, where you follow up healthcare workers to transfer and expand that to social care workers. So we would love to do that work. And I think you're absolutely right, particularly the direct impact on residents at the moment, about the changing demography of the workforce and how that might impact in terms of infections is something that has been on our minds in any case. So yeah, I think there's a huge program of work around that. Our challenge is we could have 8 or 9 different sub-programs of work, and that would be great to set that up over the coming years, but we're going to need some more people.
Well, I think after this lecture, you will have converted more than the willing to this program of work. I'm sure you'll have some volunteers coming to work with you. Now, I couldn't finish my questions to you without moving away from infectious diseases and thinking about how we integrate chronic disease monitoring and understanding of the epidemiology of chronic diseases in a holistic, patient-focused way of thinking about health in care homes. Again, in COVID, we saw the very strong connection between unmanaged and poorly controlled chronic diseases, obesity, and your risk of developing severe COVID and dying from COVID. So it feels to me that as part of understanding and being in this space, taking that whole patient view might be as important as infectious disease epidemiology. What do you think of that? And would you agree? And are you collecting that data? Could you speak a little bit more? Because it sounded very infectious diseases to me today.
Yeah, so that's a very fair challenge. So the reason we've done it in this way is all about this action point that I've mentioned. So what we didn't want to do is to be in a situation where we say we're collecting lots of data, but we're not very clear about what's immediately going back. Okay. So by having that focus on infection, we can say you're going to get back information on infection that's relevant for infection prevention control in your care homes. However, completely take the point that that's the tip of the iceberg in terms of what we need to be looking at in this population, and that chronic diseases, dementia, I mean, there are so many things where research is needed. So what we would like to do is longer term be able to link particularly primary care data as a starting point for this, so that you do start having much richer information on those chronic conditions, but also thinking about what kind of measures you would need to be able to make meaningful assessments for those kinds of measures. And so here I'm thinking much more like quality of life outcomes. And there's work that's been going on in the DACHA study, an NIHR funded program, minimum data set, that's thinking about how you can incorporate quality of life measures through things like the ASCOT tool into electronic health records. And so it would be amazing if those are in the electronic records and we're able to pull that data, or if there are other ways of us starting to incorporate those kinds of measures. So I would say we're being absolutely pragmatic in how we're approaching this, but recognizing the potential, but trying to make sure that we don't undermine ourselves by trying to do everything and not delivering anything. And so that's the approach we're taking. But
yeah, and completely understandable. And as I said, that's just because I think for so many of us, that link between infections and chronic disease, infections and the environment that people are in, which became so apparent as we were going through the acute phases of the pandemic. And for me, as we think about legacies, always bringing to the table back, what are those interconnections? Are we missing any, or are we mindful of them as we think about infectious disease control? It's certainly been one of my takeaways, and I'm an infectious disease epidemiologist as well. So, for me, even to think like this is a key part of how I've changed. I'm going to end this session because the Bazalgette Lecture is around impact. And I think you've highlighted a number of areas where you've had impact, from policy and programs and so forth. The VIVALDI study coming out of this as well. Can you summarize, just before we open up now to the questions from the audience, and we have now a few which have come up, about what you're most proud of in terms of the impact to date? And if you project in 5 years' time, what you see the further impact being likely to be. So it's a here now, but also projecting yourselves forward. If this VIVALDI study gets embedded, what will great look like in 5 years' time in terms of impact?
Wow, that is a good question. So now, I think what I'm most proud of, I'm proud that we were able to support the pandemic response. I think that's a given. But I think it's that we have managed to navigate from that study to still be in a situation where we are getting funding, moving forward, building. And that has not been straightforward. I think that whilst everybody has acknowledged we've got to learn lessons from the pandemic, actually translating that into something concrete is quite challenging. And so I'm really proud that we've been able to build those partnerships and have the foundation for this program. In terms of the long-term impact, what I would really like to see is a total transformation of how we monitor outcomes in social care, in care homes, and how we do research in this setting. So we have hospital episode statistics. I mean, all of us will complain about that, but it's still pretty useful. And we need an equivalent of that in some format for social care, so that when the Care Quality Commission are doing their inspections, they are armed with data. And so when care providers and people in care homes want to be able to advocate for better care, they are armed with data. And I think maybe that's been the biggest lesson, was the biggest lesson for me during the pandemic, is that if you have reliable statistics, people will listen to you, ministers will listen to you, and there is not that is not generated regularly for social care, and it does social care a massive disservice. So I think it's the empowering through data to drive better outcomes, advocacy, but also to get the answers to how you deliver better care quality in those settings.
Yeah, just wonderful to hear that. And I think it's such a great point as we are now working, we have a new government, new administration, new priorities for the NHS and the health service as we're creating a new 10-year health plan. And I think everybody's now aligned that any plan for health can't just be the NHS, but it has to focus on community, and it must focus on prevention, and it must also focus on social care. So hopefully this is the moment where we can bring those issues around data research, the work that we're doing on staffing, understanding environments, and creating a far more structured way of doing this work. So I think as we think about your current impact and future impact, I think the moment now is, this is the time now for us to be pushing on this. And I think from the faculty's perspective, we will be very keen to continue to support your advocacy in this space. So we have loads of questions for you now, Laura. All of those were mine. So let's hear from our members and to see what they've had to say. And there are lots of colleagues just saying fantastic presentation and how inspiring the talk was. So let me just acknowledge that you're getting lots of positive comments in the feed. Comments in the feed. First question is from an anonymous attendee, and the question was just wondering if quality of life of care home residents is being measured as an outcome, and if so, how? The reason being that some care homes may have very strict policies to reduce infection, for example, limiting visitors, which may not be desirable for residents. So how do you weigh up reducing infections whilst maximizing social contact and quality of life for residents? So a great question to start.
Yeah, thank you. It is a great question, and it's something that came up very regularly in the SAGE Social Care Working Group. So in terms of measuring it, so at the moment we're not, because it's not in routine data. We would love to be measuring it. So there is work going on in a project called DACHA, D-A-C-H-A, if you're interested, Google it, where they are looking at how they can embed the ASCOT measure, so that's the Adult Social Care Outcomes Framework, as a way of capturing quality of life, but in the electronic care record. So we work closely with them, and our goal over time, we're working with the same digital care providers, would be, if that is in the system, we would love to pull it out of the system. I think it's definitely an area of activity that everybody recognises. We need data on that, but how do you collect it at scale? Because that's the challenge. And then in terms of your point about trade-offs, essentially, I still don't think we have, that's one of those questions in the pandemic that was raised, but we haven't got a good solution to. So we are working with the London School of Economics and also with Sussex University to try and do some interviews with care home residents to ask them about those trade-offs. So if you had an outbreak that looked like this, or when you had an outbreak that looked like this, if your care home was closed, would that be acceptable? Or under what kind of circumstances would that be a reasonable thing to do? Or is it never a reasonable thing to do? So really trying to get some insights so that if we did have a pandemic in the future, we wouldn't just be having a public health lens on this. So it wouldn't just be protect people. It would be, let's think about those trade-offs and how that impacts on lives. So very early days, but it's absolutely on our radar to try and do work in that area. Yeah.
Wonderful, thank you. Second question is from John Watson, and as a follow-up to the question from anonymous attendee, has the research provided insights into practical measures that could be applied in care homes that would enable residents to continue to be visited by their loved ones during a future similar infectious threat as posed by COVID-19? So I suspect this around what would change as a result of your work.
Yeah, so I think that not so much as a result of our work, but as a result of campaigning from organisations like Care Rights UK and Rights for Residents, I think it would be very difficult for there ever to be a policy in future where there's a blanket ban on residents. I mean, I think that everybody has realised what a detrimental impact that has. Things that we have not been able to do that it would be great to do would be able to look at testing of relatives coming in, so understanding whether that is or isn't an important contribution. We did set up a clinical trial that we tried to do to look at testing policy, so regularly testing staff combined with sickness pay. Unfortunately, we did that trial too late in the pandemic, so we haven't been able to get clear findings from it. But I think it's more, we don't have the answers now, but with this infrastructure, we would be in a position to say we need to apply for funding to test out different kinds of infection prevention control measures in care homes, in cluster randomized trials, to try and get the answers to those questions. So yeah, John, we don't have the answers yet, but trying to create the mechanisms to be able to get them.
Fantastic. And Robin also is complimenting you on the work, this fabulous work, and that you mentioned dashboards as a key study output for policymakers and care providers and residents and families. Now, presumably dashboards will also be available to healthcare providers such as GPs. Robin's working in local authority public health. Is there anything that they can do to support your study at the local level? Because they're working closely with infection prevention and control colleagues in the NHS who support care homes as well. So I guess two questions there: the use of the dashboard and accessibility, and then second, can our local authorities help you in this work?
Yeah, so on the dashboard question, so we're working very closely with UKHSA on this. So their dashboard team is leading on the development of the dashboards because they have obviously great expertise. So in our version 1, our priorities are feeding information back to care providers, to policymakers, and some information back to residents and families. Longer term, our goal is to be able to have this dashboard used much more widely. But we are, in that cycle of funding, trying to turn this into permanent infrastructure. It's all those kinds of issues that we're doing battle with at the moment. So that is absolutely the direction we want to go in, but we've got to convince everybody that it's worth the investment. So that's where we are on that. In terms of what local authorities can do, I think asking care homes in your area to take part in the VIVALDI study, seeing if they are, that's a practical step. We're also going out and doing a lot of visits, and so we really welcome representation from the local authorities when we go and do those care home visits. And I guess making the point that the importance of data, the advocacy piece is also useful, because the more people that we can cite as these are the different stakeholders who are asking for this kind of data, that also strengthens our hand when we're trying to argue for funding.
Yeah, and I think this really plays into the expanded role of the Director of Public Health and their teams in a post-COVID world, because many of our directors of public health are far more engaged now in infection prevention and control, both community as well with the UKHSA, and then working with their DASs with social care sites. So the more that I guess we can join this up, keep our directors of public health apprised of what's happening here, and the new architecture and infrastructure that's being created, I think that might be a positive outcome as well. So maybe arising from this lecture today, how we connect you to the public health family, so that we continue to raise awareness of this work, would be a positive outcome too.
Right.
It's good to see some names I think I recognize. Roland Salmon is also asking a couple of questions. So he said, if I understood your slide correctly, it seems to imply that larger care homes or larger care home size was associated with a lower risk of COVID-19. Is this right? As it sounds counterintuitive, as I thought that studies in Scotland and Wales showed higher death rates in larger homes. So I think at the core of this question is the size of a home an issue in any way? And is there a role for local authority planning mechanisms when new homes are set up? A great question.
It is a great question. Yeah, so I assume that you're looking at our cross-sectional survey for that, because that's from the heat map. So as I said, it was a cross-sectional survey. So that kind of study is very limited. I think that there are variable reports on whether care home size is or isn't important. There's a lot of confounding, because it depends on the providers, it depends on the occupancy levels in these care homes. So I think it's hard to be very definitive. It's hard for us to be very definitive about that in that particular study. I think that there is good data on the rationale for having smaller care homes and for trying to limit limit the number of contacts, essentially. So emerging data around building about the best approach to creating new care homes, the built environment, and so forth. This is not an area I've done a huge amount on, but it's clearly really important moving forward.
Great. A few other questions coming in, and it's really lovely to see the amount of engagement that we've had on the lecture. Actually, Laura, this is really great. From Louise, thank you very much for the great presentation. It's wonderful to celebrate the achievements. And her question is that what was the hardest thing, the greatest frustration that you faced, and how did you and your team persevere? Advice for those of us working our way through our careers is always appreciated. So I'm not sure if this is on your career generally or if it's on the work itself. So I'll allow you to take it in any direction you'd like to.
Yeah, wow, that's a great question.
It's a great question. Yeah,
it's a great question. I think that first year of the pandemic was a combination of absolute terror, horror. I think you end up being under a lot of pressure in this situation because you're going to meetings and you're being asked weekly where your data is. And you don't know if your data if it's going to work, because we took a big risk around the data linkage approach. It made sense logically, but there are so many barriers around that. So I think the sort of leap of faith, greatest frustration, I think feeling like things should be happening and they're not, looking for people to thinking things would kick in and just saying that they don't. And realizing that if you want to make the thing you're trying to do happen, you have to take responsibility for all elements of it. And that's completely exhausting. But at the time, it was the only way to do it. I think what gets you through is the sense that this is really important. And actually, it's one time in your life where you could do something that really will make a difference. And it's the people that you're working with who are really putting in that additional effort for you. And I think to give some examples of that, obviously the team that you work with are critical, but you get to know them very well. It's the other people who are slightly more lateral. So we work with some brilliant people, for example, in NHS England, and they really went the extra mile or the extra 10 miles. And I felt that they understood what we were trying to do. And there was a real sort of hearts and minds alignment there. So, yeah, I think it's the shared goal, shared mission, and just being very, very determined and refusing to take no for an answer.
Yeah. So fun fact and personal story, we were all there with you at the beginning of the pandemic, but we all had different parts that we were playing. So you knew the work that we were doing on health inequalities and how they were manifest in the pandemic, in the early phases of the pandemic, and then became a sort of defining feature of the pandemic as it unfolded.
Yeah.
And everything you've just said, I can relate to about understanding where your allies are, keeping your focus on what you know is right and what needs to be done, keep moving forward in the face of a sort of opposition that you may face, because it's never easy. But we had those wins, right? And I'd see you on SAGE meetings and, we'd hear about what you were doing. But I think that period and what we learned about how we're able to move fast, how we're able to move determinedly, how we build what we're doing on evidence, I think must be a legacy, and how we collaborate must be a legacy for us. So great question that enabled us to do a little bit of reflection there on what this means and for our practice and what we learn. So I'm going to take it back to impact, because the impact question is coming up from quite a few colleagues. Jonathan Shepard's on the line, and he says he's interested in how you achieved impact, which is what the Bazalgette is all about. Were there breakthrough conversations with particular policymakers, for example, capitalizing on your existing relationships? If you're on SAGE already, and how is this and this is how engagement with policymakers first happened. How did this come about? So I think the question is, if it's about impact and changing policymakers, what were the routes that we were able to use to achieve impact, whether it's through SAGE or other relationships? Can you speak to that?
Yeah. So that was a huge learning curve for me, and proper baptism of fire, I would say. So there were multiple routes, and I would say we used every single route we could think of. So that varied from sending emails on occasion to Patrick Vallance and Chris Whitting, Susan Hopkins, not often, but when you felt there was something really important. I used my network, so people I knew from UCL, Andrew Hayward, for example, on NerveTag, he and I were very regularly in conversation. So when he knew things were coming up, he would say to me, have you got anything on it? That kind of, those sort of links, so the informal stuff. But also, I think what was most useful is we worked with a brilliant civil servant who was sort of allocated to us as essentially as our handler. That's really how I felt. And at the beginning of the pandemic, he and I would regularly be on the phone for between 4 and 6 hours a day.
Wow.
And he was, because he had worked in the civil service, he was very good at navigating to the number 10 meetings and all the different places where this information might be useful. And so I would give him a quick download of what to say, and he would then go and say it in the right place. And we did that a lot between us. And that continued for some time. And we then had another person in that post. And that's actually, it was one of my reflections back to those organizations, was that worked so brilliantly. How do we keep that kind of relationship going? You can't do it not in a pandemic, because you don't have the resources. But that is really how you are effective, because then you know the questions coming down the line. So you're hearing what policymakers want, and you're getting the information that they need back to them really quickly. So I think it's using every single strategy you can think of, really, building those relationships and trying to understand about how organizations work, and listening to those people who have been in those organizations, getting them to help you.
Yeah, I agree. And having multiple channels where you're influencing concurrently is often what's needed, both for the emergency phase of a response, but even in what we would normally call quiet time, when you're not in an acute response, maintaining those good relationships, either directly or through civil servants, are critically important. I cannot tell colleagues enough just how much the politicians we work with, whether locally or national, are always keen to look at best and promising practice, to understand how the system is functioning. And if you build those relationships in peacetime, you can actually move a lot faster when you're facing a threat. And so, yeah, completely agree. We have a few just sort of nitty-gritty questions for you. Just colleagues want to know, is this available in Scotland and Northern Ireland and Wales, and how can they get involved? Something about regional representation of the homes. When you're selecting your homes, are you looking at, what sort of representation are you looking at? Is it regional, or are you considering residential homes versus nursing homes versus dementia homes, etc.? So what are your criteria for selection and to achieve your sort of diversity?
Yeah, okay. We're England only, just to deal with that question quickly. That's just because of the data infrastructure. We would love to be UK, but we can't at the moment. In terms of the criteria, so because we're working with software vendors, we can only partner with homes that have those systems, but a lot of care homes have those systems. So that's not a major barrier to us at the moment. And in terms of which homes, so we've put out, or the Outstanding Society have put out a call to all homes, and we've invited everybody to take part. So anybody who wants to take part, if they have those systems, they are welcome to join the study. In this first phase, we have not applied criteria, and we're not sort of saying we need X number of nursing, X number of dementia. It's open to everyone. If this becomes a long-term project, then we would aim to try and make our composition as generalizable as possible. But as I've mentioned, it's quite hard to do that in the care sector because it's so heterogeneous. But yeah, that's our general principle. And we actually had a care home visit earlier this week with Gail Marzetti and a couple of people from Department of Health, and we were showing them our map. and they said, have you mapped that onto health inequalities yet? And we haven't. And so we're going to do that and try and actively recruit sites to make sure we have that coverage. So work in progress, but we're certainly very aware of the importance of doing that.
Wonderful. And the final two slightly technical questions that came in. One is strategic as well. Has CQC responded to your work in the ways that you would like? And the second is, this is the more technical one. Can you say a little more about the challenge of data linkage and access to retained data sets? And have you considered linking into other research databases, such as the UK Biobank?
Okay, so the first one on CQC. So CQC have been great. They've been really great. We've worked with Chris Day, who's their engagement lead. He very recently recorded a video actually encouraging people to take part in VIVALDI, and they're cascading that down to their inspectors. So the goal is that the inspectors will go out to care homes and ask people if they're taking part in VIVALDI. So really trying to have it completely joined up across the system, because that's a great lever to get providers involved, and that being in VIVALDI can support their inspections under well-led. So trying to join up there across the system. And then in terms of data linkage, so because our linkage is taking place in NHSE, we're prioritising the data sets that are within that environment. Definitely linkage to other data sets like UK Biobank, that would be great in future. But that's definitely something that we're quite a long way away from being able to go down those kinds of roads. But we've deliberately tried to have this in the right place across the healthcare system, so that as we hopefully see more data linkage, better investment, more investment in data infrastructure, we're in the right place to capitalise on that. That's the goal.
Brilliant. Well, Laura, we have come to the end of our time together. How fascinating a lecture you've given, and how wonderful to see so many questions coming from the audience today. We had just under 80 people who signed up for the lecture, and as we said at the beginning, a recording of the lecture will be made available, and I think the slides of the lecture, if it's okay with you, Laura, will also be available as well. Colleagues, we had a chance to do a lot of reflections today. First of all, to hear from one of our great public health scientists and the work that she's doing in an area of practice that historically had been relatively underserved, which came to the fore during the COVID-19 pandemic. And now we're looking at ways in which we create legacies to build on those lessons from the pandemic to ensure we do better by our social care colleagues, the social care system, and establish a system which enables us to be far more resilient and far more responsive should we have future threats of the nature that we experienced during COVID-19. I know that you all enjoyed the lecture by virtue of the very positive feedback that we've had in the chat. Lectures such as the Bazalgette Lecture and our distinguished lectures are really important for us in the faculty. They provide us with an opportunity to hear from world-leading researchers and practitioners. They give us a chance to understand how public health is making a difference in what is often a really challenging real-world environments we're all working in. And thirdly, they tell us about things that help to inspire us, that help us to be encouraged along the way, as our work often is challenging and hard. And it's wonderful to see examples where, despite these challenges, colleagues are continuing to push forward, to persevere, and to succeed. Laura, we're so pleased that you were this year's Bazalgette Lecture Award. Thank you so much for doing such a fantastic job. We wish you all the best with the VIVALDI study and the work and the mission you have to really leave an impact on social care. Colleagues, we'll be asking and sending out an evaluation form on the Bazalgette Lecture. We invite you to complete that so we can continue to learn about the lecture and how we can improve it. But thank you all for participating today, and I wish you all the best for the weekend ahead. Laura, thank you.
Thank you very much.